So good afternoon, everyone, and welcome to the second webinar of the JoinHealth 2024 Spring Series, which is co-organized by the Health Cluster Portugal and EIT Health. I'm Patrícia Patrício, and I'll be your host today. And today's webinar, as in all in this series, is organized under the scope of the DigiHealth PT, which is the Portuguese Digital Innovation Hub for Health, and that aims at supporting digital transformation in the healthcare sector, particularly in the smart health and e-health segments. So first of all, I would like to thank our speakers today. Their expertise will guide us through the pathway to achieving reimbursement for digital therapeutics across different European countries. The program of the webinar today will consist of 3 presentations. And each of these presentation will be followed by a Q&A session. So we encourage you to leave your comments and questions in the Q&A tool. So in the first presentation of this afternoon, we'll have Vincent Vercamer, who will provide us insights into the early access to reimbursement for digital medical devices using the French framework PECAN. Then we'll have Wim Dunford, who will delve into the Belgium mHealth reimbursement framework, focusing on digital care pathways. And the third presentation will be by José Paulo Carvalho, who will share the Hope Care's experience in the reimbursement systems of France and Germany. So thank you all for being here and for sharing your experience. Before I hand it over to Vincent, our first speaker this afternoon, just to let you know that the presentations will be available to those of you who requested by filling in the survey that we'll share after the webinar, and also that the recordings of this webinar will be available on the Health Cluster Portugal's YouTube channel. So moving to the first presentation of this afternoon, I'll start by giving you a brief introduction about Vincent. Vincent is the project director at the Digital Health Delegation of the French Ministry of Health and Prevention. He's an expert in market access for digital medical devices and in particular in the PECA Fast Track Reimbursement Scheme for innovative digital therapeutics and new telemonitoring activities. He also coordinates the Genius platform designed to streamline the journey to market for digital health innovators in France. So Vincent, thank you so much, and the stage is yours.
So, thank you very much, and happy to join this webinar this afternoon. So the idea is to give you a brief overview of the PECAN process in France, which is in a nutshell a part of a broader digital health strategy that we have, which is the Digital Health Acceleration Strategy, which is an interministerial strategy, and that we constructed with all the actors from the digital health ecosystem. And the idea is to support the innovation, and we provide lots of information for entrepreneurs and innovators through the Genius platform. So I give you the link here, and don't hesitate to go there. The idea is to help and help innovators to save time in their journey. So the idea of this strategy, it's a 7 million euro strategy to support all the levels of digital health project cycle, from the training of healthcare professionals through academic research and the technology transfer from research to industry or startups, or and the development of let's say the digital medical devices and their experimentation through clinical studies. And then the PECAN and also the Genius platform are part of the 5th stage of this rocket, which is to prepare a large-scale deployment of successful and useful digital health projects. But the idea of PECAN It's an innovative approach for and derogatory reimbursement for digital medical devices. So the idea is to give a 1-year transitional or temporary reimbursement for a digital medical device and we launched it last year, and the first solution was listed in last October. There are two kinds of DMDs that are available for PECAN. One kind of these DMDs are the DTX, so the digital medical devices used by the patient for therapeutic purposes. And the other kind of devices are the one used through a remote monitoring activity, so telemonitoring. And when you apply to PECAN, you are in a stage where the solution is already, let's say, mature on the market. So you have the CE marking, but you don't have all the elements coming from your clinical studies to provide to the health authorities the proof of the usefulness. So you don't have all the medical or scientific elements to show, okay, this solution brings an organizational benefits or medical benefits to the patients. So you have your running clinical studies, then you can apply to PECAN, you start, you have first reimbursement, and you can start your operational deployment. In parallel, you finish to complete the study and to provide the element for the final evaluation to the health authorities. And then during this 1 year, you go through that part. Eventually, if you are a DTX, you have the price negotiation, and then you are definitively listed. So it gives you the opportunity to start billing the health insurance while finishing the analysis of your clinical data and the construction of the demonstration of the digital medical device file. Sorry. So you have for the PECAN, we have a parallel evaluation instead of the sequential evaluation that we have if you apply directly to the standard reimbursement process. The part which is, let's say, scientific and medical around the healthcare benefits and positive healthcare effects are evaluated by the Health Tech Assessment Agency, which is the HAS in France, and the part regarding the interoperability and the security is done by the Digital Health Agency, so the ANS. And finally, the final decision for PECAN is done by the Ministry of Health. And let's say the target duration of PECAN process should be less than 6 months. So from your application to the evaluation, and then the final publication in the official journal that's give the starts for the doctors to prescribe, and you can start billing the healthcare insurance. So that's the idea of the process. And to summarize, so you have a 1-year pre-reimbursement, and you have also facilitated applications and simplified evaluation during that fast-track process. This is a step-by-step. So to summarize what I've said, so you apply through the platform. They just check the eligibility of the solutions, and if you provide all the necessary let's say elements, you submit all the evidence, then you got the acknowledgement from the Ministry of Health saying, okay, everything is in your submission. And then they start instructed your application. So that part can take 1-2 months, depending on if you forgot to add proofs in the process, but it could be faster. And then you have these 60 days, and at the end of this period of instruction, there is an advice or a notification of your solutions done by the authorities and the Ministry of Health. Based on these decisions, they can publish or accept publish the condition of the reimbursement, which takes around 30 days. Then you start your PECAR, and you start billing the health insurance. So to compare with let's say with the DIGA Fast Track, the PECAR is available to, let's say, similar DMDs when it comes to the digital therapeutics, whatever the risk class for the CE marking, but also for the telemonitoring activities, so the digital medical devices that are used within a telemonitoring activity. But you have an evaluation which is done by the different authorities, and then you have this reimbursement, which is in France, it's fixed and predefined price compensation. So I will show you the prices just after that. But you don't have a negotiation. You have a negotiation at the end if it's a DTX. If it's a telemonitoring, then we have predefined prices that are already published, and you know exactly at the end, depending on your level of healthcare benefits, where you will finish in terms of pricing. And of course, I listed the German DIGA, which is the most famous in Europe, but the other countries are also actively working on their own similar procedures regarding the reimbursement of or the early reimbursement of digital medical devices. So in terms of price compensation, because I said price compensation, it's not really a reimbursement, because it's a derogatory, PECAR is a derogatory reimbursement, so it's an early reimbursement that you have. So it's if you apply for a telemonitoring activity, then you have a technical fee. We call it a technical fee for the manufacturer, which is 50 euro per patient per month. And in addition to that, you have a healthcare professional remuneration, which generally is 28 euro per patient per month, which includes the therapeutic education. And if you have DTX or a digital therapeutics, then the price compensation for the manufacturer is fixed, and it's for whatever your indication is. And you have an initial fee, which applies for the first 3 months of 435 euro. And then if you have a renewal of the prescription, then it's 38 euro per month from the 4th month to the end of the year, for a total of a maximum of 780 euro per year per patient. But there is no, in this specific scheme, there is no remuneration of the healthcare professional, because the HCP is prescribing and giving access to the patient to the solution, but there is no follow-up compared to the telemonitoring, where you have a follow-up from the healthcare professional and alerts, notifications, and eventually change of medication plan and so on. Just a brief focus on the requirements that we have for the interoperability and the security. So depending on the solution, you will have to implement the different requirements, especially for a telemonitoring activity. You will have all these elements. If it's a DTX, it's a lighter, because you will mainly have GDPR requirements and the portability, which are part of the GDPR, and also the securing of the patient access to the DTX for telemonitoring activity, because you have healthcare professionals that are accessing your platform. Then you have to secure the healthcare professional authentication and identify this healthcare professional into the national database of the healthcare professional. And you also have to secure the identification of the patients through the national health identity, which is the INS. So it's a unique number, very similar to the social security number for the patients. So you have all the document and necessary elements on this portal, and you have the requirements in English also of each of the elements that applies to the digital medical devices. Okay, so if you want to go further, you can also visit the Genius platform. The idea of the Genius platform is to it's a platform that we've set up with all the institutional partners to make the life easier for innovators in the digital health sector. So the idea is to save time and speed up the development. So you can find the different call for projects, but also we have, let's say, elements, the necessary elements to start your work around the reimbursement, to understand the regulation around the digital medical devices or the different actors of the French ecosystem, or also other ecosystems, because we have several sheets on the e-health around the world, in European countries, but also in non-European countries. And this, so you can visit the website, and we have a step-by-step process to explain the PECAN, who you need to contact when, in order to anticipate your developments, and also the application and the evaluation of your device. So what happened at the end of the PECAN? So I won't go through that part of the process. I will send you the slide. Just I just would like to talk about the end. So at the end, after a year of reimbursement, then you have the final evaluation. So if your evaluation is validated and the health authority says, okay, this was to be reimbursed on a definitive basis, then you just continue to bill as you've done during the PECAN. Just the price can change depending on the price negotiations that occurs during that sequence. It's maybe a little bit clear on that slide. So if you want to be listed on the list of the reimbursed telemonitoring activity, then you apply for the final submission, for the final listing 3 months before the end of your PECAN. So and during that time, you can continue to follow up the patients and so on. Then if you have a positive decision, you are permanently reimbursed. Eventually, the price goes higher if you demonstrate higher benefits. So the 50 euro per patient per month is only for organizational benefits. But if you have a quality of life benefits or morbidity or mortality benefits, then you will have a higher monthly price. And regarding the DTX, so if you want to be listed on the list of the products and services that are reimbursed in France, then in that case you will have to submit 6 months before the end of the PECAN the final elements, because in addition to the scientific evaluation of the healthcare benefits, you also will have price negotiations before being definitively listed on this list. And I think you will have some useful links to deep dive if you want to go further in a Pega application for your device. So thank you all for your time, and I'm open if you have any questions.
Thank you very much,
so
Vincent.
you can ask in the Q&A. I see. And there is no question in the Q&A, so I think
not yet.
It's either crystal clear or it's do we do the Q&A now or at the end, or how?
I think we can have some questions now if anyone wants to add, but maybe it's a lot of information, and maybe it will help after we have all the three presentations. But in any case, I had a couple of questions that I wanted to ask you. So one of them is it's a very, very specific one, and from what you presented, I understood that the telemonitoring solutions are not really prescribed by the physicians, right? So I mean, are they available in the same kind of catalog? But then who is responsible for choosing which solutions will be applied to each patient? Is it the physician?
Yeah, most of the time it's a physician.
Okay.
So for telemonitoring, so let's say the general rule will be it's the physician who prescribes the solution. Especially for telemonitoring activity, it's the case today for the activities that are already listed. So we have cardiac insufficiency, diabetes, gestational diabetes, type 1, type 2, respiratory insufficiency, chronic kidney disease, and also oncology. And in all that cases, the prescription for the telemonitoring is done by a physician. And the follow-up of the telemonitoring activity is done by a healthcare team, which includes at least one physician. But depending on your solution, the health authority, the EHIS, during the evaluation can also give a different decision based on the file you apply. But the general rule will be it's a physician that do the prescription and that of this activity.
So it's not a decision. It's not an institutional decision. It's not that hospital A chooses to use this solution, this telemonitoring solution, and hospital B, for instance, chooses to use another solution. It's really the choice of a physician.
Okay. Yeah, no, indeed, yes. Okay, so that's for the prescription. Then different hospital must use different solution. So if you for telemonitoring activity, if you are included by the hospital A and they use the digital medical device and the platform X to do that telemonitoring, they will prescribe you this platform, and they will include you in their platform, in the platform they use. It's, let's say it's 99% of the case when you are included in the telemonitoring is done by a hospital or a physician that is declared and that is performing telemonitoring. So they include you and they use the platform they have a contract with also.
And another question, it's a more general one about the whole implementation and after almost a year, I would say, of implementation of this framework. How would you evaluate the success of the framework and what is there still to be improved? So you have now had some experience in how companies interact with the organizations, with the framework, and I mean, what are their main challenges when they're applying? So can you comment a bit on that?
Yes, so for the moment, we don't have a lot of experience regarding the full evaluation process. However, we have a lot of, let's say, interest from companies to apply for the PECAN. I think it will be easier for me to answer that next year, because in the meantime we will have more experience on the different application.
Okay.
However, for example, you can have early meetings, early dialogues that are free and open with the health authority, with the HAS, before applying, and they receive a lot of demands, and they have a lot of meetings around the different clinical study methodology, or this kind of or the demonstration of the positive healthcare effect, and so on. So from my perspective, on the interoperability security, it's go quite smoothly. Could take time if you need to implement additional technical requirements, but from the, let's say, from the demonstration of the healthcare benefits, it's on the hands of the HAS, but yeah.
And how can companies engage with this digital health delegation, or access those resources to support their applications to this framework? Would Genius be the right entry point?
On Genius, you have all the links to the different steps of the application process. Yes, it's a good entry point. It's not. It will help you to
redirect you to the right partner.
Exactly.
Okay.
Right people in order to apply. Sure.
Okay, so I guess there are still no questions. So thank you so much, Vincent.
You're
welcome. There might be some questions.
There is one question.
Oh, there is one now.
So if I have inputs from patients association on the implementation of PECAN, so not yet. So we don't have, let's say, we don't have a lot of time to have this kind of feedbacks, and maybe I have also another question regarding the prices.
Yeah, I'm not sure if everyone can see this question, so I will read it out loud. So it's about the prices. There's someone asking to explain about the prices again. If I properly understood, there's a fixed fee for the first year, and after that, there are negotiations with the manufacturer. And is there any boundary on the price that a company can achieve on those negotiations based on that? On what? That is the question.
So there is two different situations. If you have a telemonitoring activity, then depending on the final evaluation at the end of the PECAN, here, depending on the final evaluation, then if the commission says, okay, there is only an organizational benefit with these solutions, you get the first level, which is 50 euro per patient per month. And if the commission says, okay, there is a quality of life benefits, then you have a higher price, around 70 euro, and it goes up to, I think, for a mortality benefits, it's 90 something euro per month per patient. So that's the case for telemonitoring. If it's a DTX, if it's a digital therapeutics, then you have a price negotiation. And this price negotiation is mainly based on the scientific elements that were evaluated by the HAS commissions. So it's take into account the different healthcare benefits, but also eventually any medical economic data that helps this committee for this economic committee, the CEPS, which will do the price negotiation to give you a fair price. But the price can be higher or lower than the price compensation during the PECAN, which is, let's say, that is independent from the final price, which can be lower or higher depending on the medical value or the medical economic value that you are able to demonstrate at the end of the PECAN.
Okay. Thank you, Vincent. I guess this was the answer that was expected. So thank you again. And we'll now move to Wim. Wim is part of the telemedicine section at the Belgian National Institute for Health and Disability Insurance. He is an expert in mHealth reimbursement framework, and it plays a vital work in implementing new procedures and providing crucial support to applicants. So thank you so much, Wim, and I will hand it over to you now.
Thank you very much, and thank you for inviting me. I'll quickly share my slides. Okay, so to start, one quick slide of background information. So we as NIDI have been investigating for quite some time now the best way to implement mHealth applications in the Belgian mandatory health insurance. This resulted in the start of 2021 in the final level of the well-known validation pyramid, which defines the reimbursement procedure. But it became quickly very apparent that this procedure had major problems in implementing mHealth application in the reimbursement. So at the start of 2023, we started to evaluate the procedure and preparing a revision of it, which resulted in a new procedure starting in October of 2023. So what exactly is reimbursed in our Belgian mHealth application reimbursement framework? Well, it's reimbursing medical software that has a CE marking as a medical device and is notified to the Federal Agency for Medicine and Health Products, which corresponds to the M1 level of the validation pyramid. The application has to comply to technical eligibility criteria established by the Belgian e-health platform, which in turn corresponds to the M2 criteria. It should allow for a patient to share health-related information collected via sensors or otherwise with a healthcare provider from their own environment. And it should allow a healthcare provider to remotely diagnose, treat, or monitor a patient using that medical device. Important to note is that primary prevention is not a competence of the NIDI, it's a competence of the regions. And due to language laws, patient interfaces, if there are any, should be available in Dutch, French, and German, the official languages of Belgium. Some attention points. So registration on the mHealth Belgium website is no longer mandatory, which used to be the case. Apart from the industry, also other groups can now submit an application for reimbursement. Our framework is not limited to smartphone applications. So when we talk about an mHealth application, it also includes smartphone apps or connected devices that don't have a patient interface necessarily. And also when we reimburse mHealth applications, we'll always reimburse the care process using an mHealth application rather than reimbursing the application itself. So a care process includes reimbursing the technical solution, but also the care provided by the healthcare provider in the form of bundled payments. So That's why I call the presentation an exercise in care pathways. So some additional changes since October of last year. So now temporary reimbursements are possible, similarly to the DIGA fast track procedure. We have now a dedicated budget to facilitate the implementation of ML reimbursement, because we found that while many ML technologies offer potential savings in the long term, they often require an initial investment. So we provided a dedicated budget to facilitate that. And the idea is that achieved savings will be used for further investments in remote digital health. There are new groups that can submit an application. There has been created a dedicated ML working group that is responsible for the evaluation and implementation of mHealth applications. And there is a new, more transparent procedure with clearly defined steps and indicative timings, because the previous procedure was very unclear to applicants. So, as mentioned, there are now also other groups that can submit an mHealth application demand, reimbursement demand. So there is this industry, manufacturers and distributors of mHealth application, also professional organizations of healthcare professionals, and scientific associations can submit an application, and the hospitals can also do this. Joint submissions are also a possibility, and I would even advise involving healthcare professionals in your submission as an industry. And a small detail, but the core members of the new multidisciplinary working group can also introduce submissions. So I mentioned this multidisciplinary working group. So they are the people that are responsible for evaluating and implementing mHealth applications. We as an NIDI, we support the workings of this group by preparing the evaluations, but it is these members that have the final say, so they have the votes say it. So there is a core group of members. This is mainly composed of representatives of the healthcare professionals, physicians, but also, for example, physiotherapists are included. The second large group is the public insurers, the mutualiteiten, as we call them in Belgium. But there are also health economists and representatives of the hospital administrators that are part of this core group with voting rights. This core group is also joined by observers, mainly representatives from the industry, BMETech and Agoria, and representatives of other public services that are involved in healthcare in Belgium. For each application, this group is joined by other ad hoc members, relevant healthcare professionals and experts. For example, when we are evaluating an app for the telemonitoring of oncology patients, there will be oncologists involved. We also include the relevant patient organizations, so the patients also have a say in this process, and representatives of the competent consultative bodies, so the existing decision-making bodies that have a legal right, so to say, to make decisions in how our healthcare is organized. So these are mainly consultative bodies composed of healthcare professionals and public insurers. As mentioned, a temporary reimbursement is now possible. This is for innovative solutions that have a lot of promise. So some evidence of the clinical and or organizational benefits should already be present. To limit the applications and to ensure the quality, applications should be supported by scientific or professional associations. And the submissions should be linked to a plan of action to acquire the required additional evidence. It should not necessarily be an RCT, and this can also be an ongoing study. We foresee a default duration of 3 years, so a bit longer than Germany, but from our experience, a year is not long enough to gather the necessary evidence, but the duration may vary. We require intermediate reports every 18 months, and this period includes 6 months before the end of the reimbursement, during which we evaluate the temporary reimbursement. So the applicant is required to submit at last 6 months before the end of the temporary reimbursement submission for a permanent reimbursement. We have a new procedure and timings. As you can see, it is still quite long. We are aware of that. However, we have the ambition to move forward as quickly as possible. So the actual timings will be dependent on the complexity of the care pathways and the number of concurrent applications that have to be processed. For example, there is a period of 150 days to develop a reimbursement proposal. How long it will take in reality really depends on the complexity of the pathway. The evaluation period also includes a 30-day feedback period for the applicants. So we do an initial evaluation, after which we provide feedback to the applicants, and they have the chance to offer additional clarifications or information. And validation is by the consultative bodies, and implementation depends on the kind of reimbursement is most suited for the application. The 180 days is for a royal decree to publish that. That just takes time in Belgium. We can't do it as fast as in France. So more concrete, if you have an application and you want to have it reimbursed in Belgium, there are several scenarios imaginable. Firstly, it's important to know that we aim to provide vendor-neutral reimbursements. So when we provide a reimbursement for an mHealth application for a digital care pathway, we will define criteria to which the application that is to be used must comply. And the healthcare professional can choose whichever application that complies to these criteria. So if you have a solution and you want to enter the Belgian market, and there already exists a reimbursement that is suited for your application, but you may have some additional small advantages, you don't need to submit some application to us. If you, however, have a solution for which no suitable reimbursements exist, or your solution has very big advantages over the existing solutions, so the reimbursement has to be revisioned. We have templates on our website for which can be used to apply for a new or changed reimbursement. Before actually filling in the template, you have to show that you are compliant with the technical eligibility criteria that I already mentioned, the M2 criteria defined by the eHealth platform. There are 6 criteria in total. They are also listed on our website, but these are pretty straightforward for the most part. Criterion 3 is important because it's is about the validation of the app users to make sure that the patient using the app is the actual patient for which it was described to. It defines how the validation can be used. There are existing integrated validation authentication methods that can be used, or there are methods based on the IDAS regulation. If they comply to those minimal levels, it's also right. And it's not mentioned explicitly here, but important to know that if patient onboarding happens during a visit to the healthcare professional, for example, during a physical consultation or during a hospitalization, a physical inspection of the eID card by the healthcare professional is also an acceptable form of authentication of the patient. So the submission form itself consists of an administrative dossier, a technical dossier, scientific dossier, an economic dossier, some information on temporary reimbursement, if that's the case, and supporting information. The supporting information and the administrative information are pretty straightforward. I won't go into detail, but important to know is that an office in Belgium is not required in order to submit a reimbursement application, but the submission has to be done in one of the official languages of Belgium. So it's not possible to submit an application dossier in English. So about technical aspects, it's mostly informative, and there is asked information on the cloud storage, on data transfers in the case. Additional attention has to be paid when data is transferred outside of the European Economic Area. Ideally, this doesn't happen. There is a question asked about operating systems. There are, however, no hard cutoffs on the percentage of patients that must have a suitable device. That being said, an application that is only available on iOS, for example, would be a bit problematic. And there is the option for the applicant to mention additional certificates they may have obtained for the application of in general, but currently no additional certificates are mandatory. So the scientific information that needs to be provided starts with the description of the patient population, both quantitative as well as qualitative. Important to know is that we are not necessarily interested in how much applications you expect to sell. We are instead interested in the total amount of patients that are eligible to be treated with device and compliant with the proposed reimbursement. So the application that you have, but also similar application that may be on the market. So it is this information that allows for a proper budgetary impact analysis. International data can be used if Belgian data is not available, but it has to be motivated why the data can be used in the Belgian context. After that, the current care process has to be described. This includes describing the involved personnel and describing to which medical needs this current care process may lead. Thirdly, you're required to describe the proposed care process. This includes a description of the device and its functionalities, as well as a description of the required healthcare services that are provided by the healthcare professional. Important to note is that claimed added value may be both clinical and or organizational in nature. Organizational added value may be preventing further hospitalizations or preventing the need for another medical device or an implant, or freeing up time for the healthcare professional, things like that. And lastly, the scientific analysis of the evidence supporting the proposed care process. These are currently very flexible, which evidence we require depends in a strong degree on the nature of the app and the nature of the added value, and it is very diverse. The evidence that can be submitted is, however, not limited to studies using this specific medical device. For example, a study using a similar medical device may also be used in the submission form. Or another example may be a study that investigates the added value of a more frequent follow-up by telephone. In this study, no mHealth application is used, but the intervention is pretty similar. It's a more frequent follow-up. And this section also includes the possibility to refer to endorsements of patients of healthcare professional associations. And lastly, the economic information starts by a description of the costs. Again, both the medical device itself and the accessories, as well as the cost of the healthcare services that are associated with the pathway. The applicant is then required to make budget impact analysis, two different ones actually. So firstly, there is a budget impact analysis based on the direct costs and savings. An example of a direct saving would be replacing an alternative medical device or replacing monthly follow-ups with the healthcare professionals. So with a very direct link, things that the mHealth application replaces. But there also has to be a budget impact analysis that includes indirect costs and savings, which are often the main advantages of a mHealth application. An advantage of an indirect saving, the prime example really is prevention of further hospitalizations because you start following up early on. These indirect costs and savings often involve more uncertainty, hence the requirement for two budget impact analysis, so that we can include it directly in our budgets, our internal budgets. Once again, data from a board can be used, but extrapolation must be motivated to show that it can be used in the Belgian context also. A bit of a rule of thumb is that data from neighboring countries will be more relevant to Belgium than data from, let's say, the US or Australia. So I'm here for any further questions you may have. And if you in the future have questions on our procedure, you can contact us by mail, shown in the slide here. And I would also like to make you aware that we provide the opportunity for pre-submission meetings. But these are really meant for applicants that are in the process of preparing their submission form so they are for really specific questions or problems you may find during the preparation of your submission. Thank you very much. And if you have any questions, don't hesitate.
Thank you very much, Wim, for this very comprehensive presentation. And actually, we will see if there are any questions from the audience. But I had one of my questions were actually kind of answered in this last slide that you presented, was about how can these companies get access to support or clarify some doubts about the process. So you would say that for someone who is really starting to think about this process, they should reach you through email or by email. But if they're already on the process or already with a very specific idea on what to submit and when, they can schedule one of these meetings with you. Is that it?
Yes, that's true. We do ask to send the questions to us in advance, because from time to time we need to ask information to colleagues of us from the NIDI itself or from other public services. For example, if they are more technical in nature, the questions we have to involve eHealth.
Okay. So we have already a couple of questions here in the Q&A, and I will read them out loud. So the first one is there any price list for the different apps? And the second one is related to this one, I guess. It's, can the price include hardware values?
The price can include hardware. So it's not just software. This hardware, software, healthcare services. It's a bundled payment for the whole process that we aim for. And the price list, there isn't any. So once reimbursement has been provided, there will obviously be a price list, but we don't currently have brackets for prices or anything like that. It will be dependent on the case by case.
Okay, so it's analyzed case by case. So another question that we have here is, if I understood correctly, this approach will replace the mHealth pyramid. Is that correct?
Well, yes and no. It will replace it in the sense that publication on mHealth Belgium, the website that has been made by the industry itself, is no longer mandatory. So being on their list and having obtained level 1 or obtained level 2 is no longer part really of the reimbursement process, but the requirements behind the mHealth pyramid are still there. So in that way, the mHealth levels are still present. Still have to have a CE marking and have to be registered with the Federal Agency for Medicine and Healthcare Products, and you still have to comply to the same technical eligibility criteria. It's only the mandatory publication that is not part of the process anymore.
Okay, so I had a couple of questions myself. So one of them was, you mentioned that there had been some changes in this process throughout the years, months. So what was the first motivation for these changes? Do you collected any feedback from the companies, for instance? So was it a matter of streamlining the process? What was your previous experience that led you to change?
Well, by far the biggest problem that was present with the old procedure was that it was really limited in what it could do, because we had some submissions, demands for reimbursement, but the previous procedure foresaw that a specific working group would be created, unique for each different application, and that it would evaluate the application on its value. If it was evaluated positively, it would advise the existing decision-making structures on providing a reimbursement. But yes, this was a big challenge because the existing decision-making structures had other priorities, had limited budgets, met infrequently. So in one sentence, the biggest problem was that the previous procedure didn't really lead to reimbursements. And that was the main thing we tried to address by providing this new working group, a new procedure, and a specific budget. So it can follow up the process further than only the evaluation. It does the evaluation and the implementation proposal.
Okay, thank you. And finally, you mentioned that this framework is not only available for companies, so other innovators can apply with their solutions to this reimbursement framework. I guess could it be like an individual person to submit their application, or should it be an institution?
Yeah, it's not an individual person. It's quite clearly defined. So hospitals are official hospitals. There are about 100 in Belgium, I think. And then there are scientific and professional organizations. There are also, for both of them, there are requirements. For example, for the scientific associations, they have to organize a scientific meeting or educational program every 2 years, something like that. So it's a bit more strict than just an individual person.
And would you give any specific advice to these innovators looking to navigate this reimbursement process?
Yeah, you have to really think about how do you implement it in the everyday practice of the clinician. Sometimes the process that the company of the innovator, the developer has in mind is very different from the current process that is used in the hospital. And if you want to completely change everything, it's not going to happen. It has to really fit in the current practices.
Okay. So to adjust to the clinical journey somehow. So I guess
try to involve healthcare professionals in some way would also be very helpful.
So there is another question here. So have you had any past experience with a multidisciplinary working group? Is the voting power equal across stakeholders?
Yeah, we have in many ways we have multidisciplinary working groups within the NIDI. I didn't mention the specific voting powers, but it's defined. Yeah, it's mostly the healthcare professionals and the public insurers, but it is mentioned on our website the exact composition of the working group. I can, when I submit the slides, I will add it to the final slides, a link to our website.
Okay.
These are, however, only available in French and Dutch.
Okay.
Language laws are very strict.
So thank you so much, Wim, and thank you for this very insightful questions as well. So we'll now move to our last presentation of this afternoon by José Paulo Carvalho. José Paulo is the founder of Hope Care and is renowned for in the digital health sector for pioneering advanced solutions in remote patient monitoring and digital therapeutics. His leadership has positioned Hope Care to a global forefront, securing one of the first MDR Class 2B certifications for chronic diseases. So today, José Paulo will share Hope Care's experience with the reimbursement systems in France and Germany. So José Paulo, thank you very much once again, and the floor is yours.
Okay, thank you for the kind invite. I will make a presentation. I will focus more on Germany, okay, saying our experience. Of course, here the Vincent explained really well the PECAM. We are starting also in PECAM, so it's a process. So we will explain jointly with a German DIGA process that we also applied. So I think that now you are seeing my screen, yeah.
We are.
So, a little bit of our history, it's quite important. So Hope Care, what we have done, it was to build a remote patient monitoring system that allow us to build the hospital at home. So that is our focus. In fact, in 2017, we were one of the companies that work in Belgium, process with the two, between 2017 and 18, with the government and insurers and so on, that we applied the COPD and heart failure POCs jointly with the Interpartner Assistance and Partena insurance company. But since there, what we have done is to make POCs and proof of concepts for publishing results in order that we can have a clinical evidence of the impact and patient benefits. In 2019, in the end of 2019, we decided to go to a certification of our platform, AC Alert, as a Class 2B medical device platform. Of course, we started in the end of 19, in 2020 come up the COVID, so everything was like a revolution, as you can imagine. So the process of the MDR took us 56 months to get to the certification. But of course, last year, in 2023, we get this certification. With this process, I may say that is the starting point if we want to go to a reimbursement in digital health solutions in different countries. So it means that if you are not certified as a medical device, it's not able to apply for this kind of reimbursement. So today, as I'm saying here, we are going to different countries, and these countries, namely, they have already in place several reimbursement programs that are quite different country by country. Also, it's quite important to our positioning, because when we are talking about remote patient monitoring in France, for instance, we are talking the area of telemonitoring is where we want to be. And in Germany, in fact, we are not applying to DIGA, we are applying to another framework, but I will explain why. So our position, in fact, in pyramid, the Kaiser pyramids, between the hospital, the patients that leave the hospital go at home, and we are focused to take these patients with acute and chronic conditions, and we monitor them at home. So we are in care management field, where we are, let us say, monitoring 15 to 20% of the population, general population, where we are fit. Of course, because we are Class 2B medical device, we can do that. And we can go down in the pyramid, but our status is there. Why is so important the certification? So first of all, we were the second company to have the Class 2B medical devices certification as a software. So we are only software. So it was the second company till now. And this process, of course, that took it 66 months. It's a cumulative of different certifications that we have. So we start, of course, to look into 9001 to 30,000, and then Class 2B, and of course, security with GDPR and so on. So everything is one big work that we need to do inside the companies. Otherwise, we cannot comply to have a medical device as a product in our system. So this is the second. And to show you also the progression of our customers, it was that still we have the certification last year. We had in average 4 projects per year. Most of them, it was POCs and clinical impact studies. And the average of the patients in each study is really low. So it was to make proof of concept comparison and so on. Soon we get to the MDR certification. We close with a cumulative patients of 6,000 patients. And this year, we already have 32,000 in the licenses sold in the system, saying that we were going really fast. So it means that in the last 4 months, the certification came up in October. Since there, it was pumping, right? So the certification is really emotive. So we need to have this. Of course, this is cumulative from different countries, but it means that when we go to a process that costs a lot of money, second, take a lot of time, in the end, yes, compensate, because now we can act really in the market and growing in the market. So that is the message. Finally, when we look to the reimbursement process, we need to also to think in several things. First of all, of course, Belgium, France, and Germany are the leaders. And as leaders, they make a lot of mistakes, right? So it has must be. So they are learning. Germany are learning. Belgium, they switched the reimbursement process recently, so it's a lesson learned. So every time the country starts, it means that will take some time to establish how the payments, how the solutions go to the system, and so on. So this is natural. Of course, the beneficial are the countries that are the followers, right? So the followers are learning also, and if they are in that process also, so it means that we'll take these insights, can improve their own systems with lesson learns, and then can move faster also to the process. So there's a lot of countries now going in Europe to this process, and finally there's what we call the certified countries, where Portugal is there, and NHS UK, NHS is there, and Spain is there. So it's quite different process, but it's really in the back, I may say. Also, it's quite important to say that we are talking about digital applications. DIGA is digital applications. So, for instance, PECAM is not only apps, it's about the system telemonitoring and digital therapeutics applications. So, PECAM, for instance, in France is more broader than, for instance, the DIGA in Germany. Okay, so we need to think also that is a very different approach. In Belgium, it started to mobile applications. Now they are opening, as been explained, to a process, right? It's a care process more than only the application itself. So it's completely different approach. It's quite good position, let me say. So the Portuguese case, I may highlight that is the certified process. So today in Portugal, there's a dynamic, we call dynamic telemonitoring, telemedicine process. It means that the state make a certification if the applications can go to the market, to the hospital himself. But this is quite restrictive. First of all, most of people don't know, but for instance, you need to have a bank support of 1 million euros to apply to the state, right? If you want to work with the state, you need to have this bank support. So if you're thinking a startup, it's quite restrictive. Secondly, is that this make a framework that is stable in 1 year and then don't change. For instance, the dynamic process have 4 years, don't change. And it means that don't change because it's price-based. And price-based, it means that you cannot negotiate, we cannot improve. So the innovation, it's like you stayed 4 years ago, can imagine in 4 years what technology can go, and suddenly the price is the same and always going down. So it's not really complying to the innovation. So it's really, I may say, strict and don't allow the growth. So that's why the Portuguese case. Then we have the German case. And DIGA, of course, they start in 2019, and they are learning now. They are thinking and redoing it, because there's a lot of things here that don't work also, so they are learning, and I will explain why. First of all, they only class 1 and class 2A MDR can apply today. So it means that a solution like HopeCare that is a class 2B, as we have designed it, cannot apply. So that is the first thing. The second is that when you apply, you have 3 months to apply. So it means that will be FARM, that is authority, will look to the solution and will see if this is a solution can go to a catalog, to the catalog. Meaning that when you go to a catalog, as you manufacturer, you can set your price. So imagine that I have a price and I can say, okay, this is my price, and I go, the B Pharma accept that price, and we start 12 months proving the concept. During that 12 months, it means that you are going to negotiate with how we say, statutory health insurance. In Germany, it's health insurance, statutory health insurance that will pay. So it means that you will negotiate for 9 months that price. Indeed, that will be after 12 months. If you don't agree with the price, the discussion, then there's 3 months where a board, a arbitration board come up and will decide the price. That's it. So it means that after 12 months, or you are able to negotiate with a statutory health insurer, or you will be set for a price that will be established in an arbitration board. The problem here is that for that 12 months, you need really to prove what you are claiming. For instance, if you claim that you reduce hospitalizations in X%, you need to prove it. But to prove it, in German market, you need to make a proof of concept, meaning that you need to make a trial there. And this costs a lot of money. So meaning that you need to have to make, in fact, a clinical study in a trial during that 12 months. And in the end, this will be proved and approved by the BfArM if it's okay or not okay. And these also affect the price that you establish. It means that after the negotiation of the price and after the clinical trial, they will look the price that you set up in the first 12 months, and then they will decide if it's okay, if it's higher or lower. If it's lower, it means that it's retroactively applied, so you need to pay to the state. So to give an idea, when they start in the DIGA process with the companies, a lot of companies apply. After they define and they don't prove the effectiveness of the actions, they reduce the price. A lot of them bankrupt, in fact, and others retreat from the market, and others renegotiate the price and they establish. So to give you an idea, so this was the price in 2022. So if you look here, in fact, the price, because it's a company that can say the price, one company told here, for instance, the second one, knee pain, that we will apply under 19 years, okay? One-time license. So pay one time under 90 years is okay. But you have the same, that is knee pain, like a companion, a patella, the fourth. If you look, it's 345 every 90 months. So it's so disparate, the price, right? So it means that when they start, a lot of companies put the price high, and compare with the same level, and it's a messy. So that was the first experience from DIGA. So it's really messy. Now the discussion is about, no, this must be, let us say, tuned. It's not possible one company says 119, the other says 345 every 19 months. Okay, and I give another example that is Hello Better. So if you look here in the left side, that is Hello Better, stress and burnout. So it's 1, 2, 3, 4, 5, 6, 7th. You look, the price is 599, right? So at that point, it was when they put the price. Then they make the trials, they make the negotiation, and today the price is 222. So if you can imagine, this company is cut by half of the price, and you need to repay the money that they collect for 599. So it's huge stress. So when we go to a DIGA reimbursement process today, it means that you need to have a budget. First, for the clinical trial, because you need really to apply for a clinical trial, and clinical trial is a lot of money. So that is the first thing. Second, if you launch a price, you need to be very secure in the price that you are launching, because the impact that you are claiming need to be there. Otherwise, they will analyze, cut to the price, and then you need to repay. So it means that, in fact, to go to DIGA is a huge investment. It's not getting money. You can think, okay, I can get money. Yeah, you can get money, probably, but it will be always in the end. Okay, so it's huge, let us say, investment. So you need to be prepared on that. And comparing with PECAM, because Vincent has explained really well, I think that PECAM is really more straightforward. I think they established the price for the telemonitoring, so it's 50 euros per month per patient, so it's there. You know that is the amount that you can take, and in the end, after the study and the proof that you can put, you can negotiate. But the negotiation is about to go up in the level of telemonitoring, because the benefit, if you are quality of life benefit, you will have a plus. If you have a the impact in the hospitalizations, reductions, and so on, you have a plus. And if you are reducing mortality, you have a plus. So you can expect a price between 50 to 90 because you are proving to the state that the price is there. But the basis is there to allow the companies going in the price. And most important there, also for me in PECAM, in telemonitoring side, is that the healthcare, so the clinician is getting money also. So you receive a money because he's taking care of the patient. So that is the motive. So the motive of prescription in Beckham is that the clinician is also getting money when he prescribes. So it's quite important to speed up. So it's the strategy of Beckham, and that is really, really good. So completely different from DIGA. So DIGA is a really, I may say, we need to have a very strong study to go to DIGA. You need to have a big pocket, because you need to invest a lot of money for the trial and plus the negotiation, because if something goes wrong in negotiation, you need to repay to the state. So meaning that you need to have that pocket. So it's a deep pocket when you go to Germany, okay? So finally, key takeaways and food for thoughts, in fact. So first, of course, it's quite interesting when we talk about value-based pricing, but in fact, even in Germany, it's not yet set. Okay, so it has a lot of discussion how we can define from authority or from the manufacturers of medical device how this can be evaluated. So it's quite a discussion there. But we know that if it's value-based, it can go forward. In French case, they already put the value-based. They study. They say, okay, this is 50 per patient, so that we put it as standard, and this is good for the companies because you know that we can account with that. So this is a good thing, I think. Second, in France, this prescription is made by doctors. And this is really, really good. But the motive is there. So if in telemonitoring side, if you are prescribing and you are getting money, of course, about that, it's good. So it means that we will speed up the digital adoption, and the solutions will be prescribed in competition, free competition, right? Because it's the state that established the rules, but there's a motive for prescription. Then facilitating access. Of course, marketplaces must be there. So I think that in Portugal, with medication, with the pharmacy is quite interesting, right? So you can go to the pharmacy, you can have the reimbursement from the medications that is paid by the state, and that ones that I want, that I can pay, and I want that one, I will pay. So that's at the marketplace. NHS, the UK NHS is a good example. NHS certified applications, and then you can, as a user, you can use it. Can be reimbursed or not, but the marketplace is there, so facilitate also the ongoing private sector and so on. MDR certification is a key safeguard, of course. Without MDR certification, we cannot go. So what I defend, in fact, is that we need to have different frameworks for innovation. We cannot compare a certified application in MDR with a non-certified application. For non-certified application, it must be a new framework that can be faster to get certification, faster to get the market access. So that, I think that should be the investment from the states for the innovation companies that are developing innovative digital solutions. Should be the money go there in order they can prove the concept, then can certify, because it's a long process, and then yes, you are ready to the market, but not in the same place. So as a company, for me, when I compare one solution as Open Care solution with another that don't have a certification, cannot be compared. So it's can be fancy, can be everything, but it's not certified. So we need to split this in the reimbursement side. So final takeaways. Of course, we talk here, and Wim also talk a little bit of this. Usually clinicians and hospitals, they think more about digitalization than digital transformation. If we want to have really reimbursement in digital solutions, we need to change the process. It's not feasible to apply in the same process of care process a digital solution. This must change. So otherwise, it's one more thing in the top of. You are not changing the way you care. So if you are a digital therapeutic solution, you need to change the care. If you have a digital telemonitoring solution, you need to change the care, because it's different. So and to be effective and effective cost, have a benefit on costs also. So we need to change. Then, of course, when you go to a country, each country is different. So Belgium is different, France is different, Portugal is different. So it means that as a company, when I go to a country, really change our platform, So for instance, authentication methods. In French, there's an authentication method for the healthcare professionals in Belgium also authentication process in a different way. Okay, so probably similar, but it's different. We need to develop that. We need to integrate that. Interoperability in France is mandatory. And if you go to telemonitoring, we need to apply also the security side, the standardization of information, and so on and so on. So it's like you need to tailor, in fact, the solution for each country. One don't fit all, so for sure. And finally, of course, there's a digital user disparity. First in population, Portuguese population is different from French population in digital, and the acceptance of the users, so it's quite different. And also the patient between facing the doctors. Today, the new generations is facing the doctor with the digital solutions, right? And the doctors are not there. So meaning that we need also to think in literacy, digital health literacy. We need to promote programs for that in order that doctors can be aware that there's solutions for digital solutions to prescribe, aware that there's beneficial for everyone, and aware that when he's faced is not a problem for him, it must be a solution. So, thank you.
Thank you so much, José Paulo. So, if you have questions to José Paulo or for any of the other speakers, please use the Q&A. So, José Paulo, this was a very interesting presentation, and thanks for sharing this Hope Cares journey as you expand into other markets and your impressions also about these frameworks as you have been having the chance to experience in the first place this different processes. So you have a compliment here in the Q&A from Ricardo Moura. Yeah, I'd like to, you kind of approach that here in this last slide, but what kind of advice would you give to other digital health companies looking forward to navigate these reimbursement systems in different European countries, like based on your experience? Because I would say it's quite difficult in the first place to choose where to start, because it would be, I would say, the most interesting would be to have a framework that would be applicable to all Europe, for instance. And in that case, that you could have a single application, like for what is the case for other processes that is valid throughout the whole Europe. And it might be the case that the European health data space might have an impact on that as well. And there is already a task force, a European task force for the harmonization of health technology assessment for the digital. So, but while we still don't have that harmonization, so what kind of advice would you give to the innovators looking forward to start their journeys in different countries and applying to these programs and frameworks?
Well, first of all, I think that market research must be there first, because if you want to go to a country, it's completely different. Our experience in different countries is that each system is unique. So meaning that I cannot apply what I'm doing in France to the German market. It's not possible. Even from Portugal to Spain. So it's completely different. So that is one of the things. The second is that you need to really have a good advice there. You need to find expertise there that can help you to make all this process in order that it can be fast, and then you will not spend so much time. So that is the second advice. The third is that thinking that to get the reimbursement, you need to make investment. So saying that is that, in fact, if I have an excellent platform, I go and certify, I go to French market or Belgium or German, I need to adapt immediately. So this is an effort, an investment. So it means that if you think that you have everything ready and go, no, you don't. So that is a huge mistake. So you need always to rethink that you need to have an investment, a budget for that. then the implications is not to the next month, don't exist, that take time, because if you have interoperability, you need to prove the interoperability with the French system and German system. The codes, for instance, that you need to interchange in the systems and so on are different. So it means that suddenly you need to go in a way that is really local, not health space. Okay, I think the interchange of health data it's a good thing, yes, but in operational point of view, is not there. Will take a lot of time.
And you mentioned something that I find really, really relevant, and it makes a lot of sense. But now that you mention it, is the fact that you should get some experts, some local experts. So how can you find, or did you find these local experts? Who did you contact? Like what kind of organizations, for instance, can help these innovators apply to these frameworks? We heard from Wim and from Vincent. They have their own offices and their own platforms to help people access this information. But I guess that you were thinking about having your own experts, like people who understand the system more than only the reimbursement system itself, the healthcare system, for instance, and how the physicians are involved in the process, for instance. Is that relevant?
Yeah, it's relevant because I give an example of our experience in Belgium in 2017. When I arrived there, it's quite interesting. Recently, they are two countries, in fact, the Dutch, the Flemish, and the French,
Yeah.
right? And so everything changed immediately. So what I'm saying is that if you don't have expertise, local expertise, you will take more time, in fact. So you need to, of course, there's the platform, for instance, the Genius from a French background is great. You can have everything there, but when you go to the practice, in fact, is not so easy. So you need to have some guidance and some help on that guidance. Same in Germany. If you don't have that guidance, you don't have access. So it's really, really. I think my advice is to have always someone there. The best practice for this is always the partners that you can have. So, right. So as a company, usually you have partners in these countries. So try to, with these partners, to find the best approach and the best persons.
Thank you. So, yeah, Juliana has a question.
Yeah. I have a question for José Paulo. As you were saying, there will be a need for a lot of investment for this process, and I was thinking how easy is to involve investors and get funding for this phase of the process of entry the market.
Yeah, that I think is $1 million question. Okay. Well, I think that
I'm asking this because at this point you have already your product certified as a medical device, so
I think that is a process because first of all you need to have investors to certification, right? So because you have to make all the studies and so on, so you need to have this funding. Of course, one part of the funding can come from PRR, right? So the resilience programs or EU funding and so on. So some of part of it, but you need to have VCs on board in order that they can to allow that. So that is the first phase. The second phase is after you have certification. Well, start being easier to get money, right? So that now you are certified, you can go to the market, so you can make a business plan for that market. You can apply to investors in order to ask money to enter in these markets. But of course, for that, you need to have a clear vision, a real strategy, setup, and so on. So it's important to have that in order that you can collect money, right? So that will be the natural process of a startup, right? So where you are raising money, first level seed money, Series A, CDA, and so on. So that is the natural way of being.
Okay. So the other question that I had it's for Vincent. I think Vincent was already answering me in the chat, but I can do the question again. That was once we need, most of the times we will need to have the clinical validation for the product to have to get the CE mark. So do we need to do this again for this reimbursement process or not? Can we use the same data that we already obtained for CE marking or not? That was my
Yeah, so any data that was previously obtained can be, of course, added to the submission. It won't be not necessary, and it's contrary, rights to the ethics to do the same things and the same study again. However, let's say most of the CE marking or most of the data that are collected or for the demonstration for around the CE marking are around the accuracy, the sensitivity, specificity, or the security of the device. While the data that are expected for a PECAN, for any reimbursement, if you apply to a health tech assessment authority, the purpose of this application is on their side is to evaluate the health benefits, so any positive healthcare effect or organizational benefits or quality of life benefits. So it's most of the time it's not necessarily the same data that you used for the CE for demonstration around the CE marking. Of course, you can add that, but you probably have running clinical studies to demonstrate the benefits of your solutions. And that's why where PECAN applies, that you already started this data collection. You show, okay, these are the studies that I am running. By the end of the year, I will be able to provide you the results. In the meantime, can I be reimbursed for this device?
Okay.
Then at the end of the year, you apply, you put the data, they say, okay, the benefits are there or not, and then you are definitively reimbursed or not, depending on, of course, the evaluation.
Okay, thank you.
So we have another question in the Q&A. I guess it's for José Paulo, but maybe Vincent and Wim can also join this discussion. And I guess that Wim already addressed a bit this topic in his presentation. But for José Paulo, so in your opinion, is it possible to have a value-based healthcare study that has been previously made in Portugal and try to apply it in other markets?
Well, in Germany, no. It's mandatory to make inside the country. So if you try to apply, of course, they accept to enter Indiga in just 3 months, but after that 3 months, you need to make a trial inside the country. So that is, I think, is the best difference from the PECAN. Okay, PECAN is more open, and I think the Belgian process, I think, is more open. But again, you need to prove in the country. So even in PECAN, after 12 months, and correct me if not correct, but after 12 months, you need to prove the impact in order that you can prove if your quality of life benefit or if you are in other range of the level. So,
and I
if
guess
you already demonstrated the value in Portugal, then you can also directly apply for a definitive listing in France, and data coming from another country, same to Belgium, it's accepted. Of course, you have to explain and why it can be transposed to the French context, but let's say if the study was performed in Portugal, it should be okay. If the medical context is very similar from one country to another, at least within the European countries.
Yeah.
Okay. Thank you, Wim. I don't know if you want to add.
Yes, the level that you can use data from another country in Belgium also depends a bit on which data you want to use. Clinical data about the patient will be very similar because the patients in Belgium, the demographics in Belgium are very similar to the demographics in Portugal. But if you are comparing data on the organizational impact of your solution, it will be a bit more challenging to show that this can be used for the Belgian context or other healthcare personnel involved in Portugal. Pricing is different. The ways of financing is also different. So that may be a bit more challenging, but it's not impossible.
Okay. Thank you so much for your feedbacks. And we have one last question here from Ricardo Moura about the number of companies that are already receiving this reimbursement in each of the markets. Do you have that data that you could share, Vincent and Wim?
So, yeah, please.
Only in German. German 63 today published. So there's a website online that you can search. It's 63. So if you can imagine, since 2019, it's really
low. Yeah.
Yeah, for the moment, for the PECON, we have one that is running, and we have a few other that are in the current process of evaluation, and let's say a large part of the application will be probably in the near future. In DIGA, they were at 4 DIGA for a very long time. Then it goes up after a while.
So in Belgium, currently via our procedure, our ML procedure, there are no reimbursements implemented. There are implementations that are somewhere in the decision-making process, but are not yet being implemented, to show again that we needed to change some things. There have been pilots, there have been indirect financing in that way, but the proper reimbursements are not yet there.
Okay.
And one thing that should be what's changed compared to the situation of 2019 is that now any new product must be put on the market under the MDR. And for most of the software, let's say it's not class 1. In the past, most of the software around DTX were class 1. Now it's very narrow possibilities for class 1, especially if you are in the monitoring space.
That is a good point, because we had that problem in the beginning. So the classification for us, it was class 2B, so it's hard. And because we tried to go to the class 2A, and in the end, after authority survey us, and they say, no, it's a class 2B. And that is a challenge for the software solutions today, because class 2A is mandatory, but that is there. But of course, if you are talking about AI or something like that, well, you probably go to a 2B very fast, and the authority will say that you are 2B. It means that you need to go to the clinical validations and so on. So it changes everything. So yeah, I think that for all companies, let's say only software that are going to the process of the MDR, need really to be sure the classification. Otherwise, they can be surprised in the middle.
Okay, so we're getting to the end of this webinar, and I would like to thank you all for this invaluable participation and insights into this wider topic of reimbursement in Europe. And I guess that everyone understands that we're still learning from each other, and you've heard from some of the pioneers in this field in Europe, as José Paulo also mentioned in his presentation, and that comes with some challenges as well. And we can all benefit from this learning and try to develop our processes in a better and more streamlined way possible. So we understood also that these are evolving processes that have some implications that come either from the regulatory, but also from the evaluation frameworks that have impacts on this different reimbursement frameworks as well. So thank you so much once again, and thank you to all participants for for being here with us this afternoon. I hope this has been relevant for your everyday's work. And before we close this session, just a couple of notes that I would like to invite you to the following webinars from this series. We'll be having the next webinar on the 7th of May, and it will be about software as a medical device and the regulatory implications of AI. So registration is free but mandatory. So I invite you all to join us for another exciting webinar. And I would also like to invite you to follow the Health Cluster Portugal's and the IT Health website and social networks to know more about these and other activities. And regarding our Digital Innovation Hub, there are several services that you may benefit from. So I also would like to invite you to check the website of this project or the web page of this project on our website. So have a nice afternoon still, and see you soon.
Okay, thank you. Bye-bye.
Bye.